Dr. Michelle Melicosta. She will be talking about respiratory and ventilatory rehabilitation. Dr. Melicosta obtained her MD from Brown University in Providence, Rhode Island, and then completed her residency in pediatrics at the University of Minnesota's Hospital and Clinics in Minneapolis. She is an assistant professor of pediatrics at Johns Hopkins School of Medicine, and she is also the director of the inpatient rehabilitation unit at Kennedy Krieger Institute. She has extensive expertise in managing these children during their stay, immediately after their acute onset of neurologic deficits. So she'll be telling us how to teach children to breathe using their abdominal muscles if the book is not enough.
I'm going to share my screen here, the book. So thank you guys very much for asking me to come back and talk a little more since last year about respiratory rehab in AFM. Some of the material at the beginning of these slides, I'm going to go over a little bit quickly because I've presented it before, but if you have questions, just pop them in the Q&A and Christina will tell me to pause and slow down. So respiratory issues in AFM, differing from traumatic or upper motor neuron spinal cord injuries, we have kids who just have extreme flaccidity, not just in their limbs, but also in the chest wall. So they have increased compliance, they have really poor recoil, and they have just an incredible tendency to develop atelectasis. They have a decreased ability to produce effective coughing. They have increased production of secretions and a decreased ability to clear them. In addition to all that, once they've spent a significant amount of time on a ventilator, they get atrophy and dysfunction of their diaphragm that'll just increase with time. And our observations in kids with AFM is that the degree of dysfunction that we've seen in these kids, and we're often getting them after they've spent, anywhere from a month to a number of months in an intensive care setting, and the degree of dysfunction kind of is beyond what we might expect when, like, say, the surgeons who go in to do pacers, tell us what the diaphragms look like. So that's sort of interesting. This is just a very typical chest x-ray of a child at age 3 who came to us from the ICU for admission, and you can just see they're a little hyperinflated. They've got really low diaphragms and already starting, though, over on the right to have some atelectasis and all exactly the sort of picture we expect. So how common is respiratory failure in AFM? So early on, in the first 2 to 4 years, about 25% of patients were reported to require ventilation at some point during their illness, in the acute phase, and then less moving forward. By 2018, 2019, there were a number of reviews where it was high as 40 to 65%. And in most of those studies, between 10 to 20% had a persistent requirement for support, meaning once they had discharged from the intensive care setting, from their acute hospitalization, they were still requiring ventilatory support. Since 2020, kind of looking at updated data as we've had a little more time now with AFM, and the numbers vary depending on where you're looking, which is also kind of interesting, and I'll leave it to the epidemiologist if they want to comment on this later. But for example, Lucille Packard had about 60% of their kids requiring ventilation during that intensive care stay. At 3 years out, 26% of their patients were still requiring ventilatory support. Kind of similar to the 2 European studies that are here. But then I saw studies from the Pacific, from Japan, and also I think one from UCLA where the numbers were a fair bit lower. So it's just curious whether those are just, these are really small numbers, right? Because this is a rare disease. And so is it really a meaningful difference, or is it just a factor of the small sample size? But overall, we're definitely seeing that somewhere around half of the kids with AFM do wind up on a ventilator in that acute setting. and somewhere between 10 to 25% are still requiring it a couple of years out. So when children admit to our unit, they've left the intensive care setting. We might be seeing them for that first initial rehab admission. We also now have a number of children, some of whom I'll be talking about later, who are here for repeated bouts of inpatient rehab. And in all of those admissions, our goals are kind of, excuse me, similar, which is we really want to manage secretions. We want to prevent atelectasis and improve aeration. And we really want to activate that diaphragm and stimulate it so that we minimize the amount of atrophy and dysfunction. We definitely do, again, depending on the age of the child and their degree of respiratory control, we do sprints off the vent. We do SIMV vent settings to try and encourage breathing over the vent rate for children who are able to do that. And then we definitely see a role for the diaphragmatic pacing. There's, and this is from Roy Under's chapter actually that he wrote in a book, basically talking that we see the diaphragmatic pacer is not only to help get the child work towards being off the ventilator, and I'm going to talk more about that in a little bit, but also to treat that disuse atrophy of the diaphragm. So we were talking about E-stim, this I think of it as kind of like E-stim for the diaphragm. So the patients who are here, who are on ventilation while they're with us, we definitely prefer volume control settings, typically at a higher volume per kilo than I see in other kids on ventilators. Typically, pediatrics, we say 6 to 8 cc's per kilo. These kids generally I'm at 10 to 12 cc's per kilo to prevent collapse and atelectasis, keeping their PEEP around 5 to 8, but definitely the lowest that we can get it while maintaining that good lung expansion. During the day, we do try to wean the support as the child tolerates. I'll talk more about the pacing in a minute, but we do try to decrease the respiratory rate on that SIMV mode to encourage them to breathe over it. And then when they are able to breathe over the vent, doing sprints off the vent that might start at like a minute, 5 minutes, and then really gradually increase following their end titles and their ability to generate negative inspiratory pressure. A lot of bronchial hygiene, the secretions are definitely a problem. We do obviously nebulizers, mucolytics, inhaled steroids, chest PT, including IPVs. So we have been using intrapulmonary percussion like the Metaneb since 2016 with our AFM patients. It's definitely better tolerated in the older children. So some of these kids who come to us, at least initially when they're 3 or 4 years old, don't tolerate it very well, but we definitely have used it with some older kids. So we had done an initial review of our experience with children with AFM who came in. Of our first 19 inpatient admissions, 10 of them were requiring some amount of respiratory support on admission. That could be being on full positive pressure ventilation or on CPAP or BiPAP. All of them received respiratory rehab with just lots of pulmonary toilet as described. And by the end of their initial acute inpatient admission, 8 of those were able to decrease the amount of support they required by discharge, whether that meant going from positive pressure to CPAP or BiPAP, or decreasing the vent settings. And 2 of them eliminated their need for respiratory support completely by discharge. So diaphragmatic pacers are, I think that we talk about a lot. So phrenic nerve pacing has been used since the 70s. Since 2011, there's been the first publications on intramuscular diaphragmatic pacers in children, using laparoscopic mapping and then implanting the electrodes that then the wires come out percutaneously, but does require an intact phrenic nerve for this to be successful initially in terms of generating an actual contraction. It certainly still serves as stimulation without that, but it's unlikely to cause a contraction that's going to lead to successful ventilation. The data on pacers is limited. So at the time of our initial study, we had 2 children who had pacers planted. In both of them, it was more than 6 months after the onset of their AFM. One was a teenager. He developed AFM at age 13, had a pacer that was placed 27 months after onset. And by about, I want to say it was about a year later, not even, less than a year later, he was able to be off of the vent for about 6 hours a day. I don't see notes in our outpatient medical record of follow-up with him since, but by report from staff who've been in contact with the family, he really disliked the sensation, and it wasn't providing him enough time off the vent that he chose to continue. So my understanding is he's not using it any longer, but I haven't seen him personally to follow up. The other one is a now 9-year-old who had onset of AFM at age 3, and his pacer was placed 14 months later. And at his last admission, he had actually discontinued the use due to pain with the pacer firing. And while he was here this spring, we actually restarted it, and that was in February 2022. And by discharge, he was able to be off of his vent rate while awake. But when we attempted to increase the amplitude of the pacer further than that to do any further weaning of pressure, he couldn't tolerate the sensation. He had ultrasound that definitely showed that the excursion of on his right diaphragm actually was greater with the pacer and pressure support than it was with a vent rate, which was interesting. On the left side, it was reversed, and it was about half of that with the vent rate. So I think the fact that sensation is often preserved in acute flaccid myelitis is one of our challenges. Some of the other patients I'm going to talk about in a minute have also had times where they've stopped using it or have not been able to tolerate the increases that we would like to see due to discomfort with the pacer firing. It can also be, somebody had mentioned anxiety earlier, and these are young children, and it can be just anxiety provoking for them as well. There was also concern with the initial 2 patients I mentioned that there was a significant amount of time between the onset of AFM and the placement of the pacer. And so was sort of diaphragm atrophy due to that long period of disuse contributing to it being less successful. So since that time, we've placed pacers in 4 further children. One of them was actually done about a month after injury, before they even left the intensive care setting and came to us for their first rehab bout, with kind of the thought that maybe less diaphragm atrophy, better outcomes. So here are their, oh gosh, let me see if I can make this, and I apologize, there's a lot of junk here. Thank you. So these are the 4 patients, and what I've listed is their age at onset of AFM as well as the date. The phrenic nerve EMG that is done, and I don't know if Matt Elric is on this call, but thank him for doing these and documenting them so nicely. The diaphragm ultrasound, if one was done prior to the pacer placement, then the date of the placement, and then underneath that I've listed the time frame. So from onset of paralysis to placement of pacer, which you can see in this group of patients was 20 days at the earliest and 1 year at the longest. And then the time after pacer insertion when we did the evaluation that's documented there. And there are different evaluations that are done. 2 of these patients had documented where we measured tidal volume, exhaled tidal volume, and minute ventilation, but the other 2 did not, so I left that out. All of them have had diaphragm ultrasounds. And it's interesting because I'm not sure whether what we're able to measure, I mean, again, first of all, these are really tiny measurements. We're talking about millimeters, and there's a certain amount of position, and luckily we almost always have the same person doing the ultrasound, so we don't have a lot of inter-operator issues, but also cooperation and effort is still a part of this. And so sometimes we're seeing results on the ultrasound that don't necessarily match what we're seeing clinically. So when I look at the kids, if you look at the very bottom, I'm not, primarily a researcher. I'm a simple unfrozen cave woman pediatrician. And so what I really care about is, well, are these pacers actually helping these kids get off their vent? So all of these 4 patients are able to be off of their rate. For 3 of them, it's all day. For 1 of them, the last time I saw documented, it was between 4 to 8 hours. But only 2 of them are able to actually be off the pressure support, meaning they're totally off their vent. 1 of them was up to 2 hours and the other one was up to 45 minutes. And physiologically, I don't think there's any reason they couldn't go longer. I think with that patient, again, it was anxiety and discomfort. And so hopefully as they get older and we continue to work with them, we might be able to increase that time. But those findings don't necessarily correlate very well with what we see on diaphragm ultrasound. They do seem to correlate with that those 2 patients were the ones who had some intact phrenic nerve, or some, at least they didn't specifically measure the phrenic nerve and the EMG on the second patient, but they were able to see some diaphragm twitching. So that actually seems more predictive to me than what I'm necessarily seeing on the ultrasound. So that's a lot of numbers, and I apologize. But I do think that as we continue to encourage these kids to use the pacers so that they do get that sort of conditioning part of it, as well as hopefully with time increasing tolerance to the pacer firing and allowing us to fine tune that, that we, I would love to see these kids be able to get off. I mean, 2 hours is pretty good, but if you could get a good chunk of time, like 4 or 6 hours a day, that would really be a significant quality of life issue. So I'd really like to see that. So and the kid who had it the earliest is probably the one who has the least benefit right now. But I think that has more to do with inconsistent use and, kind of post-insertion variables, that because they're not someone who gets their care here anymore. So that I'm not clear on kind of what is going on with that in the home setting. But it's an N of 1. I still think it's useful to do it early whenever possible. I don't think there's any value in waiting if once the decision is made to go ahead and place it. If it can't be stimulated because that phrenic nerve is just too damaged, then assessing for intercostal to phrenic nerve transfer is another option. And again, I think there was someone else was speaking more about nerve transfers, so I'm not my field, but definitely something that has been done with one of our patients and is a possibility to help this be more successful. And then if the diaphragm is completely unable to demonstrate response to direct stimulation, then probably long-term ventilator use is going to be needed, and we can just start kind of educating the family about that and planning for that. And I'm going to stop sharing.
So thank you so much, Michelle. Do you have any personal thoughts on usage of diaphragmatic stimulation versus phrenic nerve stimulation?
That's a really great question. And I don't have enough experience to have a strong opinion. I think we have one patient who actually had both implanted, which was interesting. And when we looked at the ultrasound, we actually, the most recent ultrasound he had, there really was not a significant difference in diaphragm excursion between one or the other system, which was interesting. But he was also one of the patients who had some diaphragm twitch in the OR at placement. So presumably some phrenic nerve activity left. Yeah, I don't have enough experience with the Avery. I do think that it's, there's certainly a lot of data supporting its use in adults with these kinds of injuries. And I think there's something sort of nicely physiologic, right, about stimulating the nerve that is meant to stimulate the diaphragm and letting it kind of, as opposed to, we place 4 leads on the diaphragm and does it does that impulse travel, so I think it's very promising, and I think it'll be really interesting, to get more data. I mean, one of the things is, as some of you guys know, we had a surgeon at Hopkins who was interested in placing some of these pacers here, instead of us having them sent out to other facilities. And unfortunately, we lost him a year and a bit ago. But I know that there's been those discussions ongoing about surgeons who are going to maybe join that group. So I think it'll be really exciting to see what the differences are and what the outcomes are with those kids.
Thank you so much.